Great. Hi, everyone. I'm going to give it a minute or two for folks to just hop on, and then we'll get started. Erin, why don't you give me the word when it's good to start rolling?
Sounds good. Okay, we have about 50 folks, the critical mass here, so you can go ahead and get started, Ellie.
Terrific. I just want to thank you all for joining us this morning. We are so thrilled to have Dr. Jeanne Marrazzo joining us, the director of NIAID, the National Institute of Allergy and Infectious Diseases. And before I begin, this is an Alliance member only discussion. If you are not with an Alliance member organization, and also if you are with the press, if you wouldn't mind, please hop off now and shoot me an email, and I'll connect you with our director of membership to talk more about joining Research America. So thanks, and I'm sorry about that. This is an Alliance member only discussion. So as I said, today we are joined by Dr. Jeanne Marrazzo, and we are just so thrilled. We have so many questions that have come in advance, and of course I have a million of them. So Dr. Marrazzo, can we just go ahead and get started?
Yes, I am ready. Hopefully you can hear me okay, and I'm thrilled to be here. So thank you, Ellie.
Terrific. So NIAID's scope is broad. If you think about from asthma to every infectious disease, can you talk a little bit about the Institute's remit?
Yeah, it is very broad. So if you look at our mission, it is actually twofold, and it's important that people understand we are the only institute that has this kind of dual mission. So first of all, of course, we are charged with advancing basic science as well as the clinical component of science investigation across the fields of infectious diseases and immunology and allergy. What that really breaks down to, of course, are the major buckets there. So allergy, immunology, HIV as a very big component of our portfolio, and then the non-HIV infectious diseases. And then you could also separate out the emerging infections and the biodefense work as well. So I kind of think about it in those buckets. But the other thing that people may not realize is that we are actually charged with the need to respond to public health emergencies and urgencies. So pandemic, of course, is the quintessential example. Right now, we're dealing with H5N1, which I know there were several questions about. So we do have to be at the ready, and it's one of the things that I think is a little bit unique about us.
Dr. Marrazzo, can you, how does your role, how does NIAID's role intersect or align with BARDA's role, for example, in a situation like that, in a pandemic situation?
Yeah. It's a great question, because we're now really learning that in real time as we figure out how to respond to the emerging issues with H5N1. So remember, BARDA is really tasked with sort of the development of particularly vaccines and medical countermeasures that are going to be used for wide scale implementation. So we generally focus on the discovery phases as well as phase 1 and sometimes phase 2. Once we get candidates for vaccines in particular to phase 2, we generally hand it off sometimes to industry, but sometimes to other governmental organizations, depending on what's going on. So it's been great to work with BARDA in the H5N1 space, because of course the vaccine has been such a big point of discussion. So I would say we emphasize early discovery as well as the early phase investigation of the products that we're talking about, and BARDA is a little bit farther down the line.
That makes a lot of sense. you can tell I'm going off script because I can't look at you and look at this.
That's okay. It's
It's
much nice.
okay.
It's much more fun that way, I think,
Yeah, I
honestly.
love it.
Yeah.
You mentioned NIAID's work in the HIV arena, and it would be hard to overstate the
Mhm.
impact both public and private sector have had. I was looking at these data that, HIV/AIDS was 100% fatal, 11-month survival in the
Right.
80s, and the survival went up a little bit in the 90s, but it was pretty much still a fatal disease, and now it's chronic, manageable if you can afford and get the treatments. So I think there's some perception that, okay, all is well, things are done, and yet the cost and burden of those treatments, and the fact that globally we're still struggling because of PEPFAR. We've done so well, but we're still struggling to get to everybody. Tell me a little bit about your vision for the AIDS work that NIAID does and the significance of that.
Yeah, this is obviously a topic that's very near and dear to my heart, having been involved in this for a really long time. There's so many directions we could take this conversation, so you're gonna have to tell me if when I should stop. But I will just point out that just yesterday or today, the CDC released its HIV surveillance report with data from 2022. And what is incredibly sobering to me is that the number of new infections that are diagnosed in the United States in that year was about little over 38,000, not down at all from the 40,000 that we have been talking about since I have been doing these kinds of talks.
Oh my Lord.
The second piece, I mean, the incidence, if you look at the incidence, it's down a bit to around 33, but it's not a giant win. If you look at the incidence in specific age groups, there are some encouraging trends, largely in younger men who have sex with men, and that's almost certainly because of an uptake of oral pre-exposure prophylaxis or PrEP. The problem is we just have not been able to get those biomedical prevention tools to the other groups who need it. That would be older men and certainly women. We have not been able to touch the incidence in women in the United States for ages. The other challenge is if you look globally, of course, there's a very similar situation with women in sub-Saharan Africa. The incidence remains unacceptably high. And even though we think that oral PrEP works pretty well in women, even if you take it 4 days a week or so, or possibly even event driven, although we don't have the data to show that, it's just not being taken up. It's really not. So thinking about what motivates these populations who still really are clearly not driven to access this one tool that we have, is going to be really important. Are they going to go to long-acting injectables? Very big issues with access and cost, right? As well as the need to have more data on those long-acting products in women who are pregnant, lactating, or want to get pregnant. So the whole issue of trying to expand the tools we have,
Yeah.
especially for women, is huge. The other issue, of course, is we can't talk about this without talking about the role of stigma in limiting access to these tools. Again, having witnessed way too many new late stage HIV diagnoses in young men in the Deep South in my previous job. Much of that was because people just did not access. They couldn't go to a PrEP clinic. They certainly weren't going to go to an HIV clinic. It was way too stigmatizing. It was way too kind of out of their comfort zone. And that we see, especially as same-sex behavior is being not just demonized but criminalized globally. So
And
very,
the
very,
cost of
very,
that, the personal cost.
very big challenges. Very big challenges. So those are just a few of the things that I would mention. I will say that there has been some pretty good news in the past couple of months around HIV vaccines. The work
Yeah.
from the CHOVDs, I mean, really this idea of essentially training the immune system to try to create a germline source of B cells that will make broadly neutralizing antibodies. That's like really cool, and I
Yeah.
really hope that people are. I think it sparked some hope that I haven't seen in the vaccine field in a long time. So, you know, I And we are also looking, I should mention, in terms of other biomedical interventions, in addition to the cabotegravir, there are a couple of oral products, lenacapavir in particular, that are being studied with very long-acting profiles. So maybe every 3-month pill, maybe a dual prevention pill where you give
Wow,
women birth
amazing.
control. So anyway, I'll stop there,
No, no,
but
no, I'm
there's a
really
lot.
grateful, and
There's a
let me
lot.
no, and let me switch to another topic we're seeing in the chat, completely understandably, COVID and long COVID
Yep.
both. What is NIAID's role now in both of those arenas?
So certainly in COVID, and we have been saying this for a long time, we cannot take our eye off those darn coronaviruses. They are, as you know, probably been reading about the flirt variants. There's now an increase in COVID in Singapore, which kind of we should pay attention to, because remember, that was a place that was an excellent sort of marker of disease trends in Southeast Asia, which often predated what we saw in the Western Hemisphere. So, and some people are even talking about a potential spike this summer, given not just this new variant, which doesn't seem to be a giant immune but is worth watching, but more importantly, waning immunity from our last booster, right, which was last fall. My understanding is that the ACIP has a meeting in early June to kind of review the state of the epidemiology and the need to think about what a new booster might be, which clearly would be different, I think, than what we got last time. So we are very involved, not only in thinking about ongoing coronavirus vaccine work. We've got a lot of work still focusing on potentially a pan coronavirus vaccine, which would really help a lot with this sort of variant chasing, path that we continue to have to go down. But also treatments. And I should mention, we are involved in the trial that is comparing 2 doses of Paxlovid for management of long COVID. So maybe I could just talk about long COVID for
That
a
would be
second.
terrific, yeah.
So long COVID, when the sort of congressional allocations were made, they involved 3 institutes, with the lead taken by the National Institute of Heart, Lung, and Blood, and then companion work from the National Institute of Neurologic Disease and Stroke, and then us. The bulk of the effort, including what people often think of, which is the RECOVER trial, which is the prospective cohort study of people with long COVID, which was really designed to try to figure out how to define endpoints, right, and define subsets of long COVID. That's all been led out of NHLBI. We have been active participants, we've been in dialogue, so we know what's going on. Where we have been, I think, more involved is starting to think now, what are the next steps? One of our investigators, John Beigel, is leading the study that I just mentioned, where it's 2 different regimens of Paxlovid, looking at whether it will improve long COVID, because of course there are some people who have found evidence of persistent virus in the setting of long COVID, although I should say the data are not consistent. So I think that's a really important one. Thinking forward, what I would really like to do, and this is really premature, so it's just in the works, so you're getting a preview, is to think more carefully about how we could work, probably with the neurology folks, to design a really integrated, hypothesis-driven strategy for post-viral infectious inflammatory syndromes. And that would include long COVID and myalgic encephalitis and chronic fatigue syndrome, because
Wow.
there's probably a lot of commonality. We know there's clearly immune dysregulation after these infections. We don't really understand them. And you could even include Lyme disease, frankly, in that. So I think that, again, this is only my 7th or 8th month, so still trying to get a handle on all this. But I would really like to see that there's a clear need for it from the community standpoint and from provider standpoints who are really struggling to take care of these patients.
Yeah, no, absolutely. And it's really exciting to think about that, to think about, that there's research out there that could actually make a tangible difference in against 3 threats, even potentially. We have already have questions in the chat and the Q&A and pre-submitted. So maybe let me go to a couple of the pre-submitted questions to start with. I know, we have an hour, but it's going to go fast, which is terrible.
I know.
So one question I thought that came in, I think was really interesting. Well, actually, this is bread and butter. We should talk about H5N1.
Yeah.
Yeah. So what's the word? What's
you could ask how much sleep I'm losing
Yeah,
because of
exactly.
H5N1. I think it is a very I think it's a fairly worrisome situation. I mean, again, it's always walking this line of wanting people to be hyper vigilant, but also not wanting to be alarmist. And I think that's kind of where I'm at. The reasons that I remain concerned is because, as people know, this is the first time we have seen this virus, not just in cows, but also in the mammary glands of any animal, at least to this degree. And this finding that we now know that the mammary glands in these animals have receptors for both the human and have receptors, I should say, for actually the duck avian flu was kind of a surprise to people. The fact that the animals are getting infected in the mammary glands with such high loads of virus, like 10 to the 7, 10 to the 6, that also makes me nervous. And then the thing that I really think we have to keep our eye on is transmission between animals in these settings, right? So we already know that cats are well, I don't know if they're easily infected, but there have been reports of large die-offs of cats in some of these farms. The necropsies that are available show extensive infection in multi-organ systems. And then we think that the cats are probably getting infected because they're drinking the raw or unpasteurized milk. And in fact, we know from some of our investigators' work that you can infect mice with this virus and cause systemic fatal infection just by feeding the mice unpasteurized milk. So the concerns I have really are related to the potential for mixing and the potential for increasing the interface between humans and infected animals. That's I think what concerns me the most. I'm also concerned that the surveillance is quite incomplete because as much as health agencies are trying very hard to,
Yeah.
as CDC did yesterday, to encourage ongoing influenza A surveillance. This is a challenging population. A lot of the folks working on these farms may be reluctant to come forward. They may be migrant workers. They may be undocumented folks. The owners of the farms may not be particularly interested in, sort of being labeled or being found out as having infected herds. So it's kind of a perfect storm of the issues around, protecting people's livelihoods, making sure the workers are safe, and ideally preventing more opportunities for interspecies spread. And then you got to wonder, do we have the right drugs and vaccines?
That was my
Um,
question, is how is that?
yeah. So we have no data on the treatment of H5N1 in humans. I mean, we know what's been used in anecdotal case reports, but there has not been a formal trial, not surprisingly. We think that oseltamivir will probably work, but like any viral pneumonia and like especially as with influenza, you need to treat really early. So if you don't treat within the first 48 to 72 hours, the benefit often is not evident. So I think that we have to keep working on developing new agents, which we have some funding devoted to, even though we do have a good amount of Tamiflu or oseltamivir in the stockpile, as well as baloxavir, which we have no data on, and I think probably can't be used as monotherapy, is what people are saying. So it has the potential to not be good,
Yeah.
but we are really working very hard to continue to develop some of these things, and we've got a couple of candidate vaccines that we are, that the Assistant Secretary's Office for Pandemic Preparedness is working on. And then, there is an mRNA vaccine that is in development. We'll see how that goes. And then a number of earlier candidates that we should keep our eye on. But can't let up the pace for sure.
Absolutely. And, one thing Research America does is we try to dispel the myth that NIH does it all, or the private sector does it all, or
Yes.
any segment of this pipeline does it all.
Yes.
And I think this is emblematic, right? And so this is a public sector, a private sector. This is
Absolutely.
CDC. This
Yeah.
is BARDA and
Yep.
ASPR.
Mhm.
Yeah,
In fact, this may be the poster child, because for COVID, at least the animal component wasn't this animal component, really, right? This is a completely different animal, no pun intended. So it's really been interesting to be on these calls with all the organizations you mentioned, and I will say there's been a lot of excellent interagency communication. So
that's terrific.
everybody's been working really hard on that.
Lessons from COVID and but it's so wonderful to hear that, because it's one of the things that we hear a bit of
Concern about. Yeah.
concern,
Yeah.
concern
Yep.
about.
Yep.
There's another question in do you have, oh, this is a fun one. Do you have any recommendations, resources, in terms of getting started in this field of research? Now, I know there's several fields of research, right? Let's say microbiology, for example. Oh no, someone coming from a data science background. Very interesting.
And wanting to get into infectious disease
Yes,
research.
I'm guessing if
Yeah.
you are joining us today and I've got that wrong, definitely correct me in the chat. But this was a pre-submitted question.
Okay. Well, I mean, it could not be a more exciting time for data science and the intersection with infectious diseases. And I'll just give you a couple of advanced examples. And I would say to get started, read up on some of the more exciting projects that are involving, and I'll give you these two examples that are involving data science, and reach out to the investigators, reach out to the teams, ask questions. People like to talk about their work. Maybe if you can go to a meeting and meet people, go up to them and talk to them about their work, tell them you're interested. These kinds of encounters can create, amazing opportunities for people to get started, even at very, very early career stages. So just get out there, I think is what I would say. One example that I think is fantastic right now is this whole evolutionary virology question of how can you use the data that we're getting from the sequences of the genomes of the animals that have H5N1, whether it's the wild birds that are really the big reservoir right now, whether it's the cow, whether it's the human, whether it's an alpaca today actually is a new one that's a new species that has just been reported in Idaho. So how do you take those and look at them over time to ask the question of evolution and when things actually happen? So this whole
In
viral
the
evolution,
biology,
it's fantastic, and it really does involve, I mean, if you don't, I mean, it's really all about the data, and if you can't really curate that data well, again, I don't know exactly what this person is asking about, but I've just been incredibly impressed with this. I mean, this is one of the things that has helped us estimate that this or epidemic, sorry, probably started as early as December and certainly in January. So that's one example. The other example, of course, is the use of artificial intelligence.
lots of questions
And
about that in
lots of
our
questions about that and how people are really ramping that up. This is not exactly my area, so others may be more precise in their description of this, but really ramping that up for drug screening. So one of our big areas of interest, and I know you, Ellie, and your team have been very, very good advocates for this work, is antimicrobial resistance, right? The WHO just, again, put out an estimate that by 2050, we may have 10 million deaths a year globally due to antimicrobial resistance. how can you increase the pace of discovery without painstakingly going out into the rainforest and collecting all these crazy compounds that might have some likelihood of activity? And so, sort of these in silico screening approaches using structures and trying to look for molecules that are very similar to known active agents, that's just taken off amazingly.
And that
So
is data. That's big
that
data.
is
Big
very
data
much
crunching.
crunching data, really intense modeling, and just like the structural. And then the third area I would say is just the use of data in the realm of structural biology. Again, I'm sounding like the fields are mixing, but when you look at what's required to, for example, model the interaction of a precisely imaged virus or antigen even with a monoclonal antibody in the setting of the real cell interaction, that is just mind-blowing. So I think for people who are minded about this and really want to get into it, the sky is really the limit right now.
Well, I've got to say, I was kind of, if I was smarter, I would have done this intentionally, but I really didn't. This is a complete perfect opening for me to do a mini pitch. And that is that Research America is hosting an early career workshop, free to all. And it's going to happen. We
Mm,
actually are having sessions every month during the month of June. The first one, really fun. It's a career tour. So we have individuals from pretty much everywhere on the pipeline, different research disciplines, to chat with you all and for you to chat with each other. And so I'm hoping we can just put the registration in the chat. I promise we were going to do this at the end, but this was such a great opening. For the early career summit. And I hope that you all will join every session if you can, or any session you want to. Let me go back to what this is all about, which is a discussion with Dr. Marrazzo. Now
mhm,
my pitch is over. Can you talk a little bit about, I'm glad we talked about AMR, fungal infections. I know that
mhm.
there are challenges in that arena, in the science in that arena, and moving forward. I also know there's great promise, particularly in the valley fever area. But I'm not, that's okay, that's the beginning and the end of what I know. So in terms of what NIAID is doing in regard to fungal infections, could you talk about that a little bit?
Yeah, it's one of my favorite topics because as an infectious disease clinician, seeing people first in the transplant setting in Seattle, and then even in the community in the South, there's a lot of endemic fungal infection. I mean, everything from cryptococcosis to histo to blasto, and then of course coccidio, which is valley fever, which is more in the western part of the country. Before I say what we're doing, I should also mention that these are important diseases as it relates to climate change, because we are seeing, as the soil warms, much more hospitable conditions, especially for valley fever or coccidiomycosis. So the range, since I was in training, it used to just be valley fever. Now it's actually gotten all the way up to the Canadian border and perhaps beyond. I'm not actually sure. I haven't been following it that closely, but so this is a big concern. So what are we doing in the fungal area? Well, in FY 2024, we'll probably spend about $150 million in this area. So it's not a small amount of money, and we have about 270 specific projects. The projects that we have are really devoted to developing and trying to see if we can get new therapies, because we really have had a standstill after the echinocandins and then a couple of new ones, not a ton of new antifungals. So we are in the preclinical space, very involved, and in fact, two of the most recent FDA-approved antifungals, otisconazole and the very disturbingly named Ibrexafungerp actually came out of our preclinical pathway. So that's exciting.
So
And
was
then
that preclinical and then did you turn it
yes,
over to industry?
yes, yes,
Oh, okay.
exactly. Yeah. And
So they
then
had to do the later stage clinical, they didn't have to,
yes.
but they did the later
But
stage.
they took it
Work.
forward, and that's how it ends up getting out there. And then the Coxie story is a great one, and I want to just spend a second on this because I just heard about this from the person who leads it in the division of
Coxsackie Valley fever?
DMID, coccidiomycosis valley fever. So this was a pretty moribund field. There was like one person really working on it, John Gagliani in Arizona. There was no funding. It was thought to be pretty rare. And then because of interest, largely initially from Congress and associated scientists, we got some funding for this and essentially started not just a research network, but now have started a Young Investigators Award specifically to get young scientists interested in
Oh,
this. So for me, when we're thinking about these emerging infections or these re-emerging infections, if you can't create a pipeline of people to kind of keep the field alive and refresh it, that's one of the ways that we end up in serious trouble because we just, we're really behind the eight ball if we don't have people who are thinking about the current concerns. So I'm very proud of
oh,
the group that
wow.
has done this. And then, there are a few other basic science fungal, but there's a lot of basic science fungal work, especially intramurally, that's going on. So it's a very big favorite topic for sure.
Yeah, wow. And
Candida
that's,
auris, I should mention Candida auris.
yeah,
Many,
please.
many in the ID world are familiar with that. That is a very worrisome pathogen just because it's very hard to treat. It's variably sensitive to all the antifungals we have, and it has been responsible for deaths, particularly in the New York region. We don't want to go down a road where that becomes the standard Candida colonizer that we have. I don't think we're there yet, but it does worry me.
Is that one that, and again, forgive me if I'm belying my ignorance, is that also considered a neglected tropical threat or?
I don't think so. I think because you
Okay.
can see Candida auris pretty much anywhere, and it's unclear why it's emerged. It's really not something that people understand very well.
If you wouldn't mind, can we take a moment on neglected tropical diseases?
Yeah.
I think that they go underappreciated, and I understand that it's more, I guess it's probably not, um, it, I don't know when we first started to see them actually
Hmm.
in the United States. I guess with travel, they've always been some incidents, but
Hmm.
certainly in the Gulf states, and again with climate change, we're seeing more. And what is NIAID's role in neglected tropical diseases?
So I'll just use a couple of examples building on your comments about seeing these infections in the United States. Sometimes we have to justify to people why we do research outside the United States. And of course, my answer is always that global health is human health. And not only do we do that so that we can study the infections where they are happening so that we can learn from them, but increasingly, we're seeing these infections in the United States, as you mentioned, almost certainly because of climate change. We've been traveling, of course, for a while, so I don't know that that's really increased. But the issue with climate change is that it has changed the footprint of the vectors, and the two diseases I think that are most notable in this regard are dengue and malaria. We now have dengue in California. We have had malaria in Maryland, an autochthonous case, so an endemic case in malaria of malaria in Maryland. And those are two areas that we have been super active in. And I'll just highlight that we have funded development of several vaccine candidates, particularly against dengue and also chikungunya, which is another one that we have seen expanding its range. One dengue vaccine candidate that I would just like to mention was developed by Steve Whitehead here in collaboration with the Butantan institute in Brazil that's undergoing its phase 3 trial assessment, but the interim results of that trial were just published in the New England Journal of Medicine. And what is very important about this vaccine and unusual is that it was designed to prevent against severe, against all 4 dengue serotypes. So you remember there's all this
Wow.
issue about, so what was great about this, at least in a single dose, it looked like it prevented symptomatic infection due to type 1 and type 2 through 2 years of follow-up with pretty good rates of efficacy, 89% and 70%. So we don't really know what the efficacy is going to be against 3 and 4. They were not serotypes detected in the study, but the hope is if you can get a pan or at least a multi-type vaccine, that could be a game changer. And you know that the dengue outbreak right now in Brazil is
Brazil
devastating.
and Puerto
Peru is really
Rico, right?
bad. Puerto Rico's bad. Yeah. And then the other example that I think I'm extremely excited about is the malaria work that we are doing here, led by Bob Cedar and his team. You know, we have a couple of malaria vaccines, the RTS vaccine and the other one, which are modestly effective. You know, I think we're going to do better with the next generation vaccines.
Yeah.
But what I think is really cool are the monoclonal antibodies that have been developed by Bob and his team. These are antibodies that are very unique because they target the sporozoite before it infects the liver. So you get bitten and the sporozoite is traveling
Wow.
to the liver. So it's the prehepatic phase. So you're really shutting down the ability of the parasite to infect the liver. These antibodies are getting better, more effective, and they are getting longer lasting. So the most recent New England Journal paper that the team published showed a 77% efficacy against clinical disease, no safety concerns, and probably lasting about 6 months. The thing that's cool about this too is that think about cerebral malaria or malaria in children, big killer, especially young kids. When they lose their maternal antibody around 10 months, they become very vulnerable to this infection. So if you could think about using monoclonal antibody to bridge that time that they're at that high risk while they're vaccinated, that could be a game changer. So those are just a couple of
Amazing.
examples that I'm pretty
Amazing. The
excited about.
lives, again,
Yeah,
I mean, and the
big
burden of
impact.
disease. But I think one thing that we've, as advocates, have to do better is make the case for the iterative effects of this of that science in terms of how it can affect progress in other areas that may be more relevant to the American people.
Hmm.
But that, you know, it sounds to me like potentially the antibodies that you're talking about, they may inform other areas of infectious
Broader
disease
implementation.
and
Absolutely.
broader
Yes.
implications.
Yes. Yes. And for example, you know, the monoclonal antibodies, the success with COVID, I think, and using monoclonals, recognizing that the viral evolution and the emergence of new strains limited, you know, their durability over time. But that isn't going to happen with every pathogen that we might target with monoclonal antibodies. And malaria is a really good example.
I want to switch gears to a completely different topic. It's a question that's in the chat, and it has to do with, I'm going to call it science um, skepticism. And I even hesitate to do that because, um, and I think this question is, you know, is there a way to kind of work into the curriculum for early career researchers or address this at early career research phase, a way of confronting the issue of anti-science or science
Hmm.
skepticism? One thing I do wonder, and I'd love to ask you about this, is that where the skepticism lies, in some sense, I think the scientific you know, method may not be what's in question here, you know. So how do we deal with the fact that there may be skepticism about policy solutions, there might be skepticism about the purveyors of science. So
Mhm.
what is your view on
Yeah.
science, trust, science, skepticism, science, kind of
Yeah.
an anti-science feel sometimes?
Yeah, this is a great question, a huge topic for us. I have a few thoughts about it. One is um, relates to how we do science. So we are used to arguing, right? We review grants, we critique them, we put it all out there. We review papers, we put it all out there. We discuss our findings, we talk about the holes in our hypotheses and in our conclusions. That's what we do. And I think during the pandemic, a lot of the communication maybe didn't emphasize that that was what was happening so much. So, you get up in the morning, you'd see a preprint, several people would weigh in about what the preprint meant and what the implications were. And I think what a lot of the public saw was confusion and basically the sausage being made, right? The sausage of
Yeah,
science. And
yeah.
and there was a lot of confusion and they're like, why can't these people get their heads together? On top of that, so that was just the normal course of the evolution of information and science. You had agencies that were contradicting each other, frankly, right? Or you had, the classic Friday, I called it the Friday night drop, where CDC would put something quietly out on its webpage. And then you were left picking up the pieces Saturday morning when you're trying to talk to your team or your hospital, epidemiologist or the surgeons about what the heck they were recommending. So, and this is public. I mean, we've talked about this. It's not like I'm calling anybody out of school. Um,
It was
so
hard, right? It was
it
just,
was really hard. And then, of course, there was an element, I think, and this is something for, I think, young scientists to think about, and it's a reason that we need diverse and really people from every background and every lived experience talking about science and communicating about science. I think there was an element of nobody who looked like me was really talking to me. We dealt with this a lot in Alabama. There was a huge amount of mistrust, particularly in the Black Belt, which is actually a farming area, because that's where Tuskegee is, and people still remember the syphilis experiments that were done hugely unethically in the Tuskegee Airmen. So there's a lot of mistrust that runs very deep. And when you continue to just get up there as what I call the oracle and just sort of say, this is what you should do, it often doesn't meet people where they're at, particularly with regard to uncertainty um, and frankly, fear. So there's a lot to unpack here. I think the lessons that we're learning are going to be coming out for many years. But one thing I really feel strongly about is engaging a team of people who looks like the people that we're trying to talk
yes,
to. And I
yes.
don't mean just skin color. I mean really in all the dimensions of diversity that we evidence. So it's really about the right communication from the right people at the right time where it's needed.
That's such a great point. It's hard to deliver on that, and it's really important, right?
Hmm. Hmm.
Jacqueline, can you join us now? Because I'm falling behind on questions in the chat and on our pre submitted ones.
Sure, no problem. Thanks, Ellie, and thanks, Dr. Marrazzo. This has been fascinating discussion so far. So let me pull up our next question. So can NIAID promote comprehensive wastewater monitoring for all illnesses in sewer water, ideally in real time, or is this a moonshot for, I'm not sure if you can answer
Oh,
this next
yeah,
part.
this is a
Now,
CDC and NIH
yeah,
question.
I can comment on this. NIH does fund some investigators who have been very active in the wastewater space, and you may have seen a couple of weeks ago a preprint that I think is now published from Boehm's group at Stanford. They are using H5N1 specific influenza wastewater tracking, and they were really some of the first to show that there was virus present in not just the areas where there were the known dairy herd outbreaks, but even outside of those areas, which probably reflects exactly what we know about milk on the shelf, right? It's kind of many places, not just around the infected herds. And then CDC just began reporting earlier this week or last week their wastewater surveillance, which is not H5N1 specific. It's influenza specific. If it's an influenza signal and it's in the summer, you're going to assume that this is not seasonal influenza, which is the distinction here. So there are a number of groups working on this, but surveillance is really the CDC's wheelhouse. We are not the surveillance people. We certainly work with them, and of course, we're looking at funding the development of new tools that might come in handy and be used in these settings, but that's really the CDC's area.
Great. Thank you.
Let me ask another question that I know is rolling around because I've heard it from some of our members. So RSV, I remember, wasn't there some new research that it was linked to another illness, another disease? Does that resonate?
It doesn't with me at the very moment, but that doesn't mean that it is not true.
No,
And if
no.
somebody,
And I think that it's so unfair to pop these questions that are just.
that's okay. That's what I'm here for. I gotta learn on it. I gotta learn
Well,
about it.
I
I don't
have,
think so.
no?
I mean, but I will point out about RSV. And again, can you guys hear me still?
Yeah,
Okay,
absolutely.
something just disconnected. I just want to, really publicly thank you for your work, because one of the reasons that we have an unbelievably effective RSV vaccine, and also the monoclonal antibody for babies, which has been a game changer in many places. I just heard some data from Spain showing a reduction in infant hospitalizations for RSV that was just staggering in Galicia. So remember, because we had such good investment, particularly in HIV vaccine development, we have developed tools in structural biology over the last 15 years that have gotten us to the point where we, Barney Grant's team in particular, were able to visualize that RSV pre-fusion protein. So I don't know if you remember this, but this is the same thing with SARS-CoV-2. When you look at the virus, you've got these spikes sticking out, and that's what you see when you visualize the virus. But when the virus actually attaches to the cell, it undergoes a conformational change. And so the cell changes it. And so your immune system is not seeing what that initial spike looked like.
Wow.
So what Barney's team just figured out is how to fuse that protein so that that's what the immune system sees. And the same thing was done for RSV and
Wow. So they
SARS-CoV-2.
can fight it. So the immune system.
Yes. Yeah. So you can
Wow.
develop an antigen. I mean, you can develop a vaccine
Yeah.
that provides antibodies to the appropriate component of the virus that your immune system needs to see. So that's just an amazing story. And we tell that a lot because, people often say, why are we investing in basic research? Why are we investing in this ability to visualize,
I
do
love that.
cool? So it is a real story of this work pays off. Same thing with things like CRISPR, Jennifer Doudna's work, which now, of course, has given us a cure for sickle cell. Nobody, I think, really thought that we would get to the point where gene editing or xenotransplantation, we would not have been able to do the pig transplant into the gentleman who unfortunately died, but many days after his transplant, without CRISPR to cut out the harmful parts of that pig genome, which are largely retroviruses. So a lot going on there, and I like to use that as a reminder to young people who are thinking, maybe getting discouraged about going into more basic science discovery, because you just never know. You never know what your
Yeah.
results. I mean, Jennifer Doudna was a chemist, who clearly was not thinking about probably sickle cell cure when she started. At least
And
if you read her book, yeah.
I think that's another challenge that the science community and advocates for the science community, and we're all intermixed, have to think about, is how to make the case that we have miles, we've come so far, but we have miles to go in the basic research arena.
We do.
You know, why? If you're, you know, if you're non-scientist and you're sitting on Capitol Hill, you know, we've invested billions and billions. Why is it still needed?
Why do we need more?
Why do we
Exactly.
need more? Dr. Marrazzo, there's the question from Jamie Nishi, our friends from ASTMH, asking about the coincidence of malaria and
Yeah.
dengue. Um,
That's a great question. I don't know the answer, but I'm happy to follow up for you, Jamie. I think the reason I probably don't know the answer is I would guess that Bob's work. So obviously for these clinical trials, you probably can't have dual infection. So you would probably be enrolled with a single infection. So we probably wouldn't know much in that regard. I would guess that this is not uncommon. And that would be, certainly I've seen patients in Lima or in Iquitos actually who had this clinically in the hospital, but I'm not aware of anybody looking at those interactions. In terms of a monoclonal antibody for dengue, that's a very interesting question. I don't know enough about the immunology and the structural biology to answer it, but we can find out.
So we have a funding question in the chat, Dr. Marrazzo. Funding for antiviral pandemic preparedness programs is expiring soon. Are there other funding
Yeah.
options, you know, outside of the R01 frame?
Yeah, so this is an area that we're actively investing interest in. You know, our as I think we haven't really talked about the budget, but the budget, we're in a flat budget this year, which is not good, but certainly not as bad as it could have been given what the initial House proposal was, which I think many of you know was a staggering 1.5 billion or 23.9% cut just for NIAID. Not for any other institute in the face of a recent pandemic. So go figure. So where with the flat budget plus the essentially withdrawal and reclaiming of many of those COVID funds, we have been left with some challenges, even completing funding for some of our marquee projects in this area. So the revamp projects, which are the vaccine and monoclonal antibody projects for pathogens of pandemic potential, as well as the AVIDs, which are the antiviral discoveries. We are committed to doing everything we can to keep those projects going because really importantly, those projects have been designed with this, especially the revamps, with our prototype pathogen approach. So remember, there are lots of viruses that can be we can worry about causing a pandemic. We can't be ready for every single one, but what we have done and what the Vaccine Research Center in particular has done and DMID is to create this plan that focuses on 9 viral families. And the revamps are very cool because ideally we would like a consortium of investigators that has the breadth to cover these families. I mean, not everybody can be a Bunya virus expert, for example. So we are really working hard to keep these going. I think that the smaller R01 grants are always really critical, but there's a lot you can do with these digitating centers, sharing technology, sharing data management, all the kinds of stuff that, and frankly, dividing and conquering is really, I think, the mode of the day.
You know, and I think this leads into a provocative question, but a good one in terms of, and we talked a little bit about this, NIAID's coordination with ASPR, BARDA, to determine kind of what gets funded by which and what makes the most, and probably I'm sure this person's also applying to prioritization.
Yeah, well, it's something, it's interesting. There's not a single simple answer other than to say that we work really closely with CEPI, the Center for Epidemic Preparedness that is very focused on vaccine readiness. We work closely with DoD, we work closely with BARDA. We're now working very closely with Paul Friedrich's office in the White House, which is the Office for Pandemic Preparedness and Response. And then you have ASPR. So all these things, everybody's kind of doing their own thing, but coordination, I will say it seems, again, this is my 8 month in, right?
Right.
Seems to be best during crisis. So, I hadn't even, I had sort of had kind of itinerant introductions to many of these folks, but now with H5N1, I've gotten to know many of these players through very frequent phone calls. So I guess my question is, how can we build what I think is probably excellent crisis level communication into a more regular kind of
Yeah,
discussion about strategy? I think that having the White House office and ASPR
Dr.
has
Friedrich,
been really
yeah.
good, because ASPR, those offices, especially the ASPR office, is probably the key to kind of coordinating and really letting everybody else know what's going on. I was surprised, I will say, when I came on board, that many people didn't know what we were doing. Many people did not exactly, like, for example, know about our CERS, which are the Centers for Excellence in Influenza Response and Research. And the CERS are the reason that we have had very early indicators of what's going on with H5N1, including access to some of the infected cows. So this has been great. It's scary, but it's great because it's an example of, you know, there's so many areas where people are working that we just don't do a good job communicating. So it's, we're working on it, and I think we'll get there. But I'd like to do it in the context of not an urgent or emergent outbreak.
Yeah, and I do think that's what Dr. Friedrich and the um Admiral Friedrich. I'm not sure which he preferred.
General.
General Friedrich. I knew it
Yeah.
was something that I was
y-
doing wrong there.
Yeah.
But
He
anyway, I'm
goes
not
by doctor. It's fine.
but I know that that's his vision too for coordination. And so another interesting question, any strategies to balance wow, this is a rough one too, another provocative financial
Yeah.
support for
Mechanistic.
mechanistic versus
Yep.
translational
Yep.
clinical. Is
Yeah.
mechanistic basic? Is that
I
is
think
that
so. I would
yeah.
guess it's basic pathophysiology, discovery, et cetera, bench, I think. If not, please correct us. Um, so a reminder, this is a good time to mention that we are in the process of
Yes.
revising and redoing our strategic plan. The last one was in 2017. This is going to be a hot area. And our strategic plan is going to be different. It's not going to just be a narrative. It's going to be, I think, more explicitly goal driven, focus and priority driven. So I think that there again is like, you can't say 10% goes to basic research versus 40% to this. Some of it depends on who is doing what kind of work and what the needs in the field are. So we, for example, would never have the malaria antibody studies if we hadn't done the foundational work at the bench, right? So this whole discovery to implementation science, to me, that is where I think we need to continue to emphasize we're not going to be on the implementation side to the point where, we are figuring out what the barriers are to getting the cold chain fixed, and if we need to deliver a refrigerated vaccine. But there are some things around access to certain products and uptake of certain products that I think we do need to be in the space of. And a good example, as I mentioned, are the HIV biomedical preventions. When you have persistent incidents of HIV like that, and we have tools that people aren't using, why is that? We should help figure that out and help understand it. So I don't think there's a given ratio. Like, I would never say, oh, we want 50% here, 40% there. It has to be specific to what questions we are trying to answer and what the urgent needs are in the field. So that's why we have to keep talking about it. We can't make a decision and then just not, we have to come back to it every year. We have to look at the evolution of the field. We have to look at the impact of the discoveries we have made and then calibrate from there.
Great. And Dr. Marrazzo, and forgive me for forgetting this, is the submission date for comments on the strategic plan still open, or has that closed? Do you
No,
guys
it's
remember?
still open. It's 5 more days. I think it's the 27th, if I'm not mistaken. So please take a look. There's an RFI out there. We can get that to you.
Yeah,
And even if you want to just like email me, you can do that. I mean, if with your thoughts, because all the input we get is valuable. I'll be reporting back this summer on what we heard, because I really do want to hear what people say. So, and hopefully that will be out early 2025.
That's lovely. I know it's noon, so I don't know if we can get the link in the chat, but it really is easy to find. Just if you Google NIAID strategic plan, you'll get there. And Jacqueline, I'm sorry I've grabbed all your time too, but Dr. Marrazzo, this has been such a privilege and a pleasure. Thank you so much for devoting a whole hour to this, and you know, just keep doing the amazing things that you're doing.
I will. Thank you. And I can't thank you enough for your support. It was fantastic to talk with you, and really appreciate so many people showing up, and look forward to continuing the dialogue.
Terrific.
Okay, thanks.
Yeah.
Thanks.
Bye, everybody.